Hello, everyone, and thank you so much for tuning in to Optimize Your Life. I have a great guest for you today. It's Dr. Erica Bove. She's going to introduce herself. She is a doctor that actually works in the infertility side of medicine, but I'm going to let her introduce herself. So, Dr. Erica, would you please introduce yourself?
Yes, thank you, Dr. Valerie. I'm so honored to be here with you today and to be with your audience as well. So, I am a double board certified OBGYN and reproductive endocrinologist, which is a mouthful. That basically means that I spend my life dedicated to women's health and not just with the sort of pregnancy aspect of things and the gynecology, but there's a subspecialty where we help people with all sorts of reproductive issues, whether it's abnormal puberty or menopause symptoms that are severe, or even today I was in the OR fixing people's uteruses. We do a lot of fertility treatment. That is a lot of the bread and butter of what we do. But
Mhm.
it's, sometimes people think, oh, you're a fertility specialist. It's actually a lot broader than that. But we do really help people build their families, right? So when people come to us and they've been trying for 6 months, a year, 10 years, whatever it be, in
Wow.
terms of trying to have a child,
Mhm.
we go through, we look at the history, we try to figure out what might be not connecting. We can order certain tests that will help to elucidate the why of things. And
Mhm.
then there's various treatments that we can offer. I also, a few years ago, decided to become a certified coach because I really saw a gap in the kind of care that I could provide for my patients. I was
Yes.
doing my best in the clinic, really trying to explain, the diagnosis and the treatment options. And I realized on a very deep level that people were not absorbing anything that I was saying.
Mhm.
And as I was in coaching for other reasons of my own life, like parenting and relationships,
Mhm.
I decided to become a coach myself. And I started to realize these coaching tools are what people need to make empowered choices. And that's when I decided to become a fertility coach and to
Mhm.
found Love and Science, Thriving Through Infertility, which
Mhm.
is my coaching practice, which helps professional women to cross the bridge to parenthood in a way that is empowered and in community and in with compassion. And I can tell you, it really works. I'm grateful that I can do this in my medical practice as well, infuse these tools, but really to dedicate the time and to create the community to help people navigate these very, very difficult and time consuming journeys.
Well, thank you so much. Thank you so much. So, what is the process like? Is it like you are a gynecologist and then you have to do a fellowship in
Yes.
addition to that? How is the process? How does
Yeah,
that?
so 4 years of college, 4 years of medical school, 4 years of OBGYN residency, and then 3 years of reproductive endocrinology and infertility fellowship. And I always say I never skipped a step. They let me loose at 33. And I've now been out of fellowship almost a decade now. And I also became the fellowship program director recently at my,
Oh,
university. And so, but the process is
congratulations.
long. Thank you. The process is long. But
Yes.
I think to be able to have, and this is really what drove me to this work, to be able to have these intimate connections with patients and families, to
Mhm.
be able to walk them through these very vulnerable moments in their lives when they so desperately want to have a child, they feel threatened that that might not be what's in store for them.
Mhm.
It is such an honor to be able to walk with my patients and believe in them, as we've talked about before, and really use my brain but also my heart to
Yes.
help figure out, where things are not connecting and what I can truly do to heal them.
Oh, okay, okay. Well, thank you so much. So now let me ask you this. Infertility, I feel like I hear it more and more. Do you, from, research, is it a problem that's becoming more prominent just in the society?
It's such a great question. So yes, it definitely
Mhm.
is becoming more prominent. So even when I was in medical school, which
Mhm.
was, I don't know, 20 years ago, we were always taught that 1 in 8 couples suffered from infertility.
Mm.
That has been adjusted now to one
Wow.
in six couples
Oh,
that struggle
wow.
with infertility. And if
Okay.
you look at, female physicians and dentists, that number is actually 1 in 4.
Really?
Yes. And if you look at female surgeons, that number is 1 in 3. So, it's
Wow.
so fascinating. I mean, we know that globally that
Mhm.
men's sperm counts are declining in every
Mhm.
single continent. So that's
Wow.
notable.
Mhm.
We do know that, with the advent of birth control and the fact that women are more and more educated,
Mhm.
that people are delaying childbearing, which it doesn't, sort of count for everything, but it does add to people struggling with infertility because many people think they'll be okay if they start
Mhm.
trying at 35, 38, 40, 42.
Mhm.
And many, many women are surprised to find out that their own body is not doing well at that age. So
Oh.
I also think we need to do a better job with education in
Mhm.
terms of helping people understand their bodies and thinking about how can we have it all and
Mhm.
plan so that people don't find themselves in these situations.
Okay, I'll come back to the planning.
Yeah.
But I wanted to ask you, so what are some of the causes of infertility among men and women? Because you talked about the declining sperm count
Absolutely.
overall.
So it's interesting. So, we kind of think about it in categories like we do with so many things in medicine. There's this bucket called male factor infertility, which basically means that there's some issue with the sperm.
Mm-hmm.
That can be helped with something called an insemination, where we concentrate the sperm and put it directly inside the woman's uterus.
Mm-hmm.
But some men, will actually need in vitro fertilization if they're going to conceive with their own sperm. That means that the numbers or the shape or the movement are so poor that
Mm-hmm.
we really need to physically put one sperm into one egg in the
Mm-hmm.
laboratory setting. So male factor infertility is one cause.
Mm-hmm.
Another big cause is what we call ovulation disorders. And so that
Mm-hmm.
means that, a woman is having difficulty ovulating every month, or perhaps they are ovulating, but the choreography around that ovulation event is not quite optimal. So a lot of what I do is help people, even ovulate at all or
Mm-hmm.
have a better quality ovulation with each month, so that when they do have sperm exposure, it can increase the chances that they have a successful pregnancy. Another category that we see is fallopian tube disease. So people might have endometriosis or
Mm-hmm.
history of ectopic pregnancies. And so, the fallopian tubes, I think of them as like the highways. They're the
Mm-hmm.
highways for the sperm on the way up, and they're the
Yes.
highways for the embryos on the way down. And if there's
Mm-hmm.
a traffic jam or a problem with that transport
Mm-hmm.
in either direction, then people might not be as efficient, and that can really create a lot of problems. Sometimes the tubes are even blocked, and there's no chance that an egg and sperm will meet. So that's another factor. Another factor, well, I mean, we can talk about lifestyle a little bit, but the diminished ovarian reserve. So, when a woman starts to be in her mid to late 30s, for the most
Mm-hmm.
part, I mean, younger women do suffer from this, but it's mostly a problem of, advanced reproductive age,
Mm-hmm.
and certainly into the 40s. It's not just a numbers issue because we know we lose eggs with time. We're born with all the eggs we'll ever have, but
Right.
it's also a quality issue. So not only do we have fewer eggs per cycle as we get older, but
Mm-hmm.
the quality of those cycles is much worse. And so sometimes it's really hard to get to a good embryo, whether
Mm-hmm.
it's in the body or outside the body,
Mm-hmm.
because the eggs are tired, and
Yeah.
the sort of machinery in the cells of the eggs has a harder time shuttling the chromosomes of the right places to go. So we see losses and non-pregnancies and those sorts of things. And then there's uterine causes, so sometimes people have like a big fibroid, which is a benign, smooth muscle tumor in the uterus. We see a lot
Mm-hmm.
of those,
Mm-hmm.
and we help people and take those out. Sometimes people just have, uterine scarring. Maybe they had to have a procedure at some point, and
Mm-hmm.
it's, you try to restore the anatomy. So there's uterine factors as well. So I'd say male factor, ovulation issues, diminished ovarian reserve, endometriosis, fallopian tube issues, uterine factor issues. And so that basically are the kind of the big categories of infertility. But there's also a lot that can be said for lifestyle. And
Okay.
I wanted to bring that up. So I think
Yes.
many times people think that nothing can be done for their
Mm-hmm.
fertility. They say, oh, we've been trying for 5 years. But I can tell you, when I take a careful history, there's usually something I can find with, what's going on. So, I practice in Vermont, where there's a high usage of marijuana. I would say
Okay.
probably at least 40% of my patients regularly use marijuana,
Okay.
which is, we know now that it's not good for sperm. Um, so I work with them and say, okay, well, why, tell me about your habits, and what does it serve you? If you have a hard time sleeping, is it because
Mhm.
you're anxious? How can
Mhm.
we treat the anxiety? All these different things. So marijuana is not good for sperm. Cigarette smoking and vaping and chewing tobacco, also not good for sperm. So if
Mhm.
somebody is really, and eggs for that matter, actually, but both of these things are not good for eggs or sperm. So if somebody is really struggling with, those sorts of habits, we work with their PCPs. We try to get them on a nicotine patch. We try to treat the underlying anxiety so that
Mhm.
they don't have these toxins in their system that are making the
Mhm.
process less efficient. If that makes
Mhm.
sense.
Mhm.
So lifestyle is really important. I think that we talked about this a little bit, like chronic stress. We know, I think that is partly why we're seeing increasing levels of infertility, is because people are very stressed. And
Mhm.
when the nervous system is amped up, it
Yes.
really negatively, it affects all the whole body, all the physiology, the ability for the body to do what it's supposed to do in terms of ovulation and even receiving an embryo. So
Mhm.
one thing I help my people with, my patients and my clients, is to reduce the stress
Mhm.
so that they can have better fertility outcomes. um, and another sensitive topic, but it's an important topic, is weight.
Right.
I think that we know that one person at a certain weight might have a very different health profile than another person at the same weight even, and
Right.
genetics are important, and insulin resistance. But I will say that we do know that women who carry extra weight do tend to be less efficient over time, with lower
Mhm.
pregnancy rates per month, and
Mhm.
higher miscarriage rates. And so I always say to my patients,
Wow.
I want to get you pregnant. I want you to stay pregnant with a healthy baby. I want you to
Yes.
walk home from the hospital with a healthy
With
baby in
the
your
baby.
arms, in
Yes.
this time. And so, we're now starting to think more about weight optimization, prior to fertility treatment. And I'll tell you, Dr. Valerie, a lot of people, they just call me up and say, Dr. Bove, I guess I didn't need you because I've lost 30 pounds with this GLP-1. And guess what? We're pregnant. And I love
Yes.
those stories because,
Yes.
it's helping people with their whole health. And we don't always need to, quote unquote, force the system with our treatments.
Wow. That's a lot. And I have so many questions now.
Yeah.
And I'm gonna start by the weight. Why is it that weight adversely affects
hmm
fertility?
We don't entirely understand. I did
Mhm.
spend 18 months of my fellowship doing brain surgery on mice to try to understand this question. Um, we think it's related to inflammation at some level, and
Okay.
it, like we talked about before, it is one body, right? The whole body is all connected. And so the fat cells do release more inflammatory markers and cytokines, and substances that travel through the body. So it's probably at some level related to that.
Mhm.
We do know that, even if obese women are ovulating regularly, that their success rates every month are lower, and their
Mm.
miscarriage rates are higher, and the birth
Wow.
defect rates are higher, and there's more complicated pregnancies. And so, like I said, my goal is to help somebody walk home from the hospital with a healthy
Mhm.
baby. And
Yes.
most of my patients, if they're coming with an elevated BMI, I'd say the vast majority of them have struggled with weight most of their lives. And so
Mhm.
I say, let's really, sort of get a handle on this. Let's help with your confidence, right? And I know that, there's a lot of, this is a body shame culture. I am all for body positivity. I will
Yes.
also say that I find regularly that when people are, losing some of the extra weight that they've carried for so many years, there can be a renewed sense of confidence and
Yes.
a lightness. People move around with more ease, their joints feel better,
Mhm.
and our medications actually work better. It's interesting. There's a
Oh.
lot of resistance to medications that we see
Mm.
when people have higher BMIs, body mass
Wow.
index, if your listeners don't know that term.
Mhm.
But what we do is, even 5%, weight loss for
Mhm.
many people, will the medications will go farther. We'll get more eggs in the next, IVF cycle. We'll
Wow.
have a successful outcome. And so it's really, but the embryo quality will be better. I mean, it's really, really, really amazing how, such a small, it's not easy, I'm not minimizing it, but something that is actually actionable can
Mhm.
make such a difference in the outcomes for people. So I think it takes a sensitive approach. It takes listening to my patients. And for some reason, people, that's never been a struggle, and that's okay.
Mhm.
But I think this can be a unifying diagnosis, and what can we do to help you in the most whole sense there is.
My goodness, wow. I didn't realize that being overweight can actually not only prevent someone, well, I did realize that it can prevent someone from actually getting pregnant, but I didn't realize that there would be a high risk of, defect for the baby and
Mhm.
even an increased level of miscarriages. That's,
Yes, and stillbirths, Dr. Valerie, I mean, stillbirths are higher, and
mm,
it's dose dependent. With every 5 points of body mass index, it goes up and up and up. And so there's definitely a correlation there. And so, and I say I have a vested interest, higher cesarean delivery rates,
oh,
higher fetal weights, large for gestational babies, shoulder dystocia. Like I mean, the list is so
goes
long,
on and on.
but it really does. I mean, I think that we have an excess of food, at least in our society, for
Hmm.
most places,
Hmm.
and yet I think we have a spiritual poverty. We are not connected to each other. We replace social connections with social media,
Hmm.
and the amount of mindless eating, emotional eating, all these things. I think we have to look at the whole picture. It's not just calories in, calories out. It's how are you medicating your pain?
Mm,
Is it with the food pantry? Is it, and again, it's the whole picture. No,
yes.
everyone's a human. It's not like we're saying everybody needs perfect behavior, but
Hmm.
how do you manage your pain? If it's marijuana, then let's talk about that. If it's
Hmm.
food, let's talk about that.
Hmm.
If you're doing everything right and still not budging the needle because of insulin resistance, let's get a handle on that too. But we
Right.
have to listen to people and their struggles and really figure out where the access points are to start to budge the needle for change.
Wow. Okay. So now I'm shifting now into stress because you talked about how stress affects fertility. How does that happen? And while you were talking about the probability of the data as far as like 1 out of 8 versus 1 out of 6, and especially when you come to talking about physician dentists, is I think you said 1 out of 6, and then after that you said 1 out of 3 even for surgeons. I
Mhm.
think that could be accounted for stress.
We think so. I mean, I think the challenging part is that stress is very hard to measure.
Yes.
It's very hard. And
Hmm.
there's all these different, new monitors that monitor, everyone has the Aura Ring these days. And, there's different monitors that look at blood pressure and heart rate and all those different parameters. But at the end of the day, stress is still subjective. And so, my theory, and there's some preliminary data to support this, my theory is that when we are stressed, it
Hmm.
increases our cortisol response, right? And so when we have a cortisol response, that then increases the insulin resistance. And, when we're in a stressed state, our heart rate is up, our blood pressure is up. If we think about the state that we need to be in to truly receive an embryo, the
Hmm.
receptivity, that is altered in a stressed state, right? The problem is our stress response is actually a good response. It helps us run away from a bear, as I
Yes.
actually had to do this weekend. I actually ran away from a bear this weekend. That's another fun
Wow.
story.
Ooh.
Yes, I did.
That would be a
But so
scary story for
Right,
me.
right. Yeah, yeah, yeah. So in that context, we want to be able to run away from the bear. But when we're running away from the bear all day, every day for
Hmm.
3, 4, 5 straight years, which is what this
Hmm.
fertility journey is,
Yes.
it starts to have a negative effect on the system.
Hmm.
And so I think it's through cortisol. I think it's through physiology. I mean, there's also a non-quantifiable aspect of it too. I can tell you when I'm about to do an embryo transfer,
Hmm.
I can tell if there is significant stress for the patient in that room. If there's a lack of belief, I can tell it's not going to work. I can tell. And
Wow.
it's,
And you're
as a
talking about
physician,
lack of belief.
lack of
Okay.
belief,
Hmm.
negative, like, and I'm not saying it's only about being positive, because if that was true, then the world would be cured of infertility. We could fix that problem. So it's multifactorial. But I
Yes.
can tell you, when I see a patient and they are shut down and hopeless and frustrated and sad on the day of the embryo transfer,
Hmm.
I can tell you, even if my transfer is as beautiful as they come, that
Mm.
embryo usually does not take. It's the
Wow.
most, and we don't know for 9 more days, right? In our world, we don't know for 9 more days if someone's going to be pregnant, but there is a mind body connection that we have not yet tapped into. There
Mm.
is a parasympathetic tone which we know
Mhm.
restores calmness, it
Mhm.
restores
Yes.
peace, it restores
Mhm.
belief,
Mhm.
all those things that actually literally help our blood to flow.
Mhm.
um, that is improved when we are relaxed, when we are calm, when we are believing, when we are not stressed. And so a lot of what I do is I help people with stress reduction, breathing techniques, embodiment, feeling our feelings and letting them go, and really trying to say, let those lower vibration frequency feelings, yes, we process them, we let them go so that we can live in the authentic hope, so we can live in the belief, so we can live in our highest chance of success.
Wow.
Yeah.
So does stress also affect the male counterpart and even the weight? Does that also affect
Yes. Yes, it's
infertility
true.
issue?
And it's interesting. I mean, when if you look at, like, say, Olympic athletes or people who undergo a lot of, like, medical students, like, the brain knows that we don't need to reproduce in the moment. We need the blood to go to our brains. We need the blood to go
Mhm.
to our, lungs and our kidneys and our liver and all those important organs.
Mhm.
But reproduction is actually optional for an individual during a brief period of time.
Of
And
time,
so
yeah.
that is the first thing to go. If the weight drops below a certain threshold, if we have significant stress like finals or something else that's very stressful,
Mhm.
chronic disease even, we will stop ovulating because the body knows we do not have the resources to be able to grow another human. And
Mhm.
so we know that that happens. We can try to overcome that with IVF, but there's still something that's not quite right
Mhm.
when we are not addressing the stress component. It's IVF just doesn't work as well, and I
Mhm.
think we need more data, but we also need more people doing the work of the stress reduction to really serve our people.
And does the heavy weight or obesity also affects male as far as
It
reproduction?
does. It does. So yes, I mean, if you can find anything you want in the literature, right? You can find studies that say yes, you can say studies that say no, but
Mm.
the overwhelming majority of data would suggest that male weight does affect sperm quality and numbers as well.
Wow.
Yeah.
Huh, that's something to really take into account.
Yeah.
So now I wanted to shift back to because I was working backward. Initially, you talked about the reproductive organ of a woman. I know that you spoke a little bit on the male, so we leave that alone for right now because we don't have 5 hours to talk about the subject, which is very fascinating. But so as far as women are concerned, you talked about poor ovulation. You talked about the highway, the fallopian tubes, and you're also talking about the uterine wall. So how do you improve? I'm going to ask those three questions so I don't end up forgetting.
Sure.
How do you improve ovulation for
Hmm.
women? That's one question. Another question is if someone has actually fallopian tubes that are stuck, because you said, you either have a traffic jam or it's completely blocked, how do you
Hmm.
overcome those kind of
Sure.
issues? And as far as fibroids are concerned, can somebody actually get pregnant with fibroids or do they have to be removed?
Good question. Okay. So for the first area, which is ovulation, you have to try to figure out why someone's having a hard time ovulating.
Mhm.
There is something called polycystic ovarian syndrome. It is a
Mhm.
terrible name for what it is, but 10 to 15% of women of reproductive age have polycystic ovarian syndrome.
Mhm.
And many people with this don't ovulate every month, or they may not even ovulate at all.
Mhm.
And so much of the time, this is actually related to what we talked about before, which is this insulin resistance pathways and carrying extra weight.
Mhm.
And just as the body kind of knows when there's too little weight, sometimes the body knows when there's excess weight, and it shuts everything down.
Mhm.
And so it's interesting if you think about it from a historical perspective, like back when we were cave people, right? Like the people who ovulated just often enough, but who could survive during the famines because they were efficient stores of nutrients.
Mhm.
Those are the people who survived during those times because
Mhm.
they were very efficient at storing the nutrients. However, in our society these days, that does not serve because there's so many nutrients everywhere that being an
Mhm.
efficient store of the nutrients, and ovulating only so often, it's a different time and a different place. But I
Yes.
like to think about it that way, to say, listen, your ancestors were the survivors, but now we've adapted and we have to figure out how to help you live your best life within this culture. And so
Yes.
figuring out the why of ovulation, usually it's polycystic ovarian syndrome. And really weight optimization and health optimization can be very helpful. Dietary stuff too, in terms of like people with PCOS tend to be, the simple carbohydrates tend to be kind of the worst for those people because they're so efficiently stored.
Mm-hmm.
So we work with dietitians. We talk about complex carbohydrates and
Mm-hmm.
protein and healthy fats, and really having a good balance of healthy exercise in there, so that, and even sometimes the GLP-1s too, we've started employing those as well to
Mm-hmm.
help people really get a leg up on this extra weight.
Mm-hmm.
And so that's really it, is to try to get a handle on the PCOS to help people. But there are medications you can give to try to help people ovulate if those lifestyle changes are not
Okay. Are
effective.
all the people suffering from polycystic ovarian syndrome actually overweight, or is there some?
Not everybody, no. I mean, there's actually a number of people who are lean
Mm-hmm.
with PCOS, and that can be a challenge, because what you do usually in those situations, what you do, I mean, you make sure that they're not underweight, right? And so
Mm-hmm.
there's that piece of it. But what you can do is you can give them a medication, an oral medication, to help them ovulate,
Okay.
and that will often work in terms of their fertility. So
Okay.
yes, that's a great question. I'm so glad you asked. The second question you asked, wait, I will say, with the ovulation, that you also have to make sure it's not the thyroid. You have to make sure they don't have a chronic disease. You need to
Okay.
make sure it's not their prolactin. So there are other endocrinology issues that can cause problems with ovulation. And if you treat those, like, treating the thyroid is pretty simple. Treating the prolactin is pretty simple. You can often help people to restore ovulation. So again, the why of things is really important.
Mm-hmm.
When it comes to fallopian tubes, that's a tricky one.
Mm-hmm.
Truly, if somebody has very damaged fallopian tubes,
Mm.
the best thing for them is going to be in vitro fertilization,
Okay.
because what that does is that bypasses the tubes altogether.
Mm-hmm.
We take out the eggs from the body. We get the sperm often from a partner. Every now and again there's a different sperm source, but some eggs and some sperm, based
Yes.
on the person's wishes. And then we combine them in the laboratory setting, bypass the fallopian tubes, and put an embryo directly inside the uterus. And so that is the mainstay for fallopian tube disease. However, if somebody does have just some filmy adhesions kind of at the end of the tube, and the
Yeah.
architecture of the tube is overall normal,
Mm-hmm.
that can make a big difference. If somebody has significant endometriosis, which is causing inflammation in the pelvis, and
Mm-hmm.
somebody has like a big endometriosis surgery, and with ablation and taking away the scar tissue,
Mm-hmm.
oftentimes people are most fertile in the 6 months following those surgeries. And so, all
Okay.
fallopian tube disease is not created equal. So you
Okay.
really have to look at the pictures, look at the history,
Mm-hmm.
and make your best determination. But
Mm-hmm.
fallopian tube disease can be hard to treat outside of IVF. But
Okay.
fortunately, we do have IVF, which can be very effective.
Mm-hmm.
And then the uterine disease, it's interesting. I tell my patients and my clients that fibroids are like real estate. It's all about location, location, location. And so
Okay.
today I saw a woman with an 8 centimeter fibroid, but that's very far away from the inside of the uterus where an embryo would implant.
Mm-hmm.
And she doesn't have any symptoms. And so after some shared decision making and some counseling,
Mm-hmm.
she decided that she wants to leave it in place, which is very reasonable.
Mm-hmm.
I saw another woman with how big was this? 2 centimeter fibroid that
Mm-hmm.
was impinging on the uterine cavity, right? So
Uh-huh.
you could actually see it coming in kind of like a golf ball in
Mm-hmm.
the uterine cavity.
Mm-hmm.
That, even though it's smaller, because of its location, that has a good chance, because it's where the prime real estate should be of an embryo implanting.
Okay.
To remove that fibroid is likely
Oh,
going to help somebody with their outcome, if that makes sense.
okay. Yes, it does make sense.
Yeah. Yeah. So those are kind of the mainstays of those treatments. Now, the male factor infertility, again, you have to look at the why of things.
Mm-hmm.
Some men have sperm inside of them. They just can't get them into the outside world due to obstructions of various
Mm-hmm.
things. And so
Okay.
there actually are urologists who specialize in retrieving sperm in
Mm-hmm.
the absence of a man being able to produce sperm to the outside world. And so that can be helpful. We can use that sperm for in vitro fertilization.
Mm-hmm.
But also, like, sometimes men have like dilated veins in that area that can be removed, and that can really improve the fertility of those men. Lifestyle changes are important. Some men have low testosterone. I'm going to shout this from the rooftops. Until your family is complete, do not take testosterone from the outside world. It kills the sperm count. About once a month,
Oh.
I see a bodybuilder who's on testosterone, who thinks
Uh-huh.
he's on it for building muscles or low testosterone, and it wipes out this. I'm seeing a couple like that tomorrow. So it wipes out the sperm count. So
Mm-hmm.
if you are a man of reproductive age and your family is not yet complete, there are other medications that can boost your testosterone, like clomiphene and anastrozole, that are not testosterone, that boost your body's own testosterone, which
Mm-hmm.
can positively affect fertility.
Oh, okay, that's very, very important. Very, very
Yeah.
good information.
Yeah.
And so, how about chronic diseases like, for example, diabetes or high blood pressure,
Oh,
let's say sleep apnea, those kind of
yeah.
diseases, do they also affect
They
infertility
do.
in men and in women?
Yes, they do actually. And so we know that basically eggs and sperm and embryos do not like a high sugar environment.
Mm-hmm.
And so it's really important to treat those chronic conditions. Ideally, we get the hemoglobin A1C to less than 5.8%.
Mm-hmm.
But I will tell you that 5.8 to 6.5, the birth defect increase starts at 6.5%.
Wow.
So, and people say, oh, what, I'm on this medication. Is that safe in pregnancy? I think we don't think about diabetes as the biggest, sort of risk factor for birth defects.
Mm-hmm.
Most people are not on these, medications, but a lot of people do have type 2 diabetes or type 1 diabetes. And so we really need to, work with people's endocrinologists, primary care doctors to treat those conditions. High
Mm-hmm.
blood pressure, interestingly. So high blood pressure, I would say, is not as much of a problem of getting pregnant, but to maintain a healthy pregnancy. Because if you
Uh-huh.
think about it,
Uh-huh.
the sort of the maternal physiology needs to then provide the blood supply to the growing embryo fetus to be
Yes.
able to be successful. And if there's high blood pressure and there's resistance at the level of the placenta,
Mm-hmm.
then that baby is not going to get what it needs to grow, and that's where you start to see fetal growth restriction and things like that. So best to treat it ahead of time so that you can set up that environment from the beginning. And there are blood pressure medications that are safe to take in pregnancy. Some are not so good for the growing baby, but fortunately, if we know about this ahead of time, like nifedipine and labetalol tend
Mm-hmm.
to be very good ones, that are very well studied and safe in pregnancy. Then you asked about one more chronic condition,
Sleep apnea, for
sleep
example.
apnea. Yes.
Mm-hmm.
I have not seen any data in men yet for sleep apnea, but I
Mm-hmm.
imagine it could exist, because we know that eggs and sperm do like oxygen. We do
Yes.
have data for untreated sleep apnea in women that
Mm-hmm.
it's not good for eggs, it's not good for embryo quality, and people do better in their IVF cycles if their sleep apnea is treated. They also have better pregnancy outcomes. So you can see it's a spectrum, right? What's good for fertility is usually good for pregnancy maintenance, but there are very good data actually that sleep apnea should be treated for the optimal outcomes.
Wow. I'm learning a lot. I'm learning a lot.
Yeah.
So, Dr. Bove, I was going to ask you, why is it so secretive? Why are people so embarrassed about the fact
Mm.
that they are going through infertility, or facing infertility in their lives?
That's a great question.
And
I
how
think,
can they, because you are a coach, that's a great question for you. How can they overcome this? Because
mhm.
does it increase the level of stress even further?
Oh, absolutely. Yes, absolutely. So when you ask people what some of the worst parts of the fertility journey are, they usually say it's the isolation.
Mm,
And I really, have been trying for years to understand why there's so much stigma and shame associated with infertility.
mhm,
Um, I think it's complicated. I think that people, sort of are taught and told that this is something that quote unquote should come naturally. And if it
mm,
doesn't come naturally, that there's, something defective about the person. And so,
mhm,
instead of viewing this like another chronic health condition like diabetes or high blood pressure or thyroid issues, there's something like, people feel broken. They feel like a failure. They
mhm.
feel like they're disappointing their spouses. I can't tell you the number of female patients I've had who have asked their husbands to divorce them, truly, because they said,
Wow,
you deserve to be a father and I can't do that for you. And so you need to divorce me right now.
my
It's,
goodness.
so you can see just the level of shame and,
Yes.
it really cuts to the core. And I think it also, when we think about why we're here as humans, not everybody is meant to be a parent, that is for sure. But many people do feel this calling within them to be a parent. And
Yes.
I think when people feel that they can't fulfill that and that
Mhm,
vision for themselves,
mhm,
it's almost like life has no meaning.
mm,
Um, And so one thing I try to do is I try to say, yes, we are going to work on this fertility journey for you. And we need to understand that your life is not defined by this reality of whether you have a child or not. You
Mm-hmm.
are a beautiful person. This is your career. This is how you love the people in your life. So helping people to understand the bigger picture, I think, is really helpful.
Mm-hmm.
And I also think, I mean, to be very realistic about it, I think that people there are judgments. People's families can have a lot of judgment
Yes.
on, if they open up and they say, oh, you shouldn't be doing this, IVF is wrong, or
Mm-hmm.
it's not natural. And I think that people really do fear what their families will say too,
Yes.
especially when there's some less supportive environments. But even with people with supportive families do experience the shame as well.
Mm-hmm.
But what I say is that shame cannot exist in isolation, or excuse me, shame only exists in
In
isolation.
isolation.
And when you shine a light, when you bring people together, when you speak it out loud,
Mm-hmm.
you dissolve the shame. And that's why
Mm-hmm.
the community aspect of what I do is so important,
Mm-hmm.
because you look around and you say, oh, you're struggling with the same exact thing that I am. Oh, wait, you are too. Oh, you are too. And
Mm-hmm.
all of a sudden the barriers break down and the isolation breaks down, so that that shame can't thrive anymore because people are coming together. So I
Mm-hmm.
think that's one of the most powerful things we can do about this problem, is to really bring people together in community.
Thank you so much. Do you find that men also carry that level of shame at the same level or maybe more
That's a
than
yes.
women?
I think they do. I think it's very interesting, and I've thought about this a lot.
Mm-hmm.
I think that men, and this is a generalization, so there's exceptions, but I think most men really are bothered by how powerless they feel in this situation, because there's much of the time there's truly nothing that they can do,
Mm-hmm.
and they're watching their wives, their partners, suffer, and all they want to do is take the suffering away. And
Mm,
so what I see is a lot of times they take that anger out on the fertility clinic themselves, because
okay.
that's their way of protecting their partner,
Uh-huh.
or they tell their partner, you just need to stop altogether, because if we could have a great life without kids, or
Mm-hmm.
don't worry about it, if we just
Mm-hmm.
stop treatment now, then this suffering is going to end. That
Mm-hmm.
doesn't acknowledge all the grief that's going to happen for people
Right.
when this is their desired imagined life.
Right.
But I think that the way that this presents for men is very different. And I think men in general are very isolated from each other. But I
Mm,
think that their own feeling of powerlessness is very profound. And they
mm-hmm.
also do not like feeling powerless when they see the people they're supposed to be protecting, suffering.
This is true. Yeah. So, one question I have, and I think that would probably be maybe the last or the second to last question, is so for a woman, because I remember you saying that overall, as life has evolved, people tend to actually conceive at a later age, maybe
Mhm.
because of trying to continue with their profession or things like that. What would you advise someone who would eventually want to conceive to do?
Good question. So I tell this to my med students all the time. I say, if you think that you are going to be able to try to have kids before you turn 35,
Mm-hmm.
it's probably going to be okay for you, right? Because most people are able to conceive under the age of 35.
Mm-hmm.
If you know that your education or a life circumstance or something, is lack of a partner even, is going to prevent you from trying to conceive until you're after 35,
Mm-hmm.
it's probably a good idea to do something called egg freezing.
Okay.
And egg freezing is not an insurance policy. I used to think of it that way. But
Mm-hmm.
it's basically saying that our eggs, when they are frozen, they do not age with us.
Okay.
So, if you freeze your eggs at the age of, 30, right? You say you're going through a divorce and you really don't want pressure to meet a partner, but you really want to be a mom someday. If
Mm-hmm.
you freeze your eggs at 30, those eggs are going to stay frozen at the age of 30 with the success rate of a 30-year-old. So
Okay.
if you go to use those eggs at the age of 37 or 38, your success rates are going to be that of a 30-year-old and not that of a 37 or 38-year-old, if that makes
Mm-hmm.
sense.
Mm-hmm.
So, egg freezing, we do this day in, day out. It's a 2-week process for the person who's undergoing it. It does involve injections, but we teach people how to give these injections. And we basically capture the group of eggs that a person would have gone through no matter what in that cycle, right? We go through
Mhm.
groups of eggs every month, not just one egg at a time. And so
Right.
I think if, and even say somebody even says, well, I can try it when I'm 34, but I really, really want a large family, or I, really, really, really want to be a mom.
Yes.
It's a pretty well tolerated process, and the success rates are pretty high. I've actually, on a personal level, I actually went through it myself, during my own divorce, and so it's really something that can be very empowering for people, as long as people understand it's not always 100%,
Mhm.
but it does sort of say, this is important to me. I'm going to put some younger eggs on ice. I don't know what the next few years are going to hold, and that can be a very proactive strategy for people for whom this is a priority.
That was really good. Thank you so much. Um, I know that there's so many more questions to be answered, or to be asked and answered. But, would it be okay for us to invite you once more to answer more of our
Oh,
questions?
I would be so honored. I would love to do that.
Wonderful. And so, how, if somebody wanted to work with you either as, their doctor or coach, how could they do that? Where could they find you?
Absolutely. So my academic practice, my actual, gloves on, helping people with procedures practice is at the University of Vermont. So if you live in Vermont, Massachusetts, New Hampshire, New York, any of those states that are within driving distance, feel free to book an appointment with me there. If you're more looking for coaching and emotional support through the process, and my coaching role, my practice is actually international. So I can help people anywhere in the world. So go to my website, loveandsciencefertility.com, and book a consult call with me. I would love to help you sort your situation. And it's truly my life's greatest honor to be able to serve in this way with the coaching tools, and to really bridge people across in a way that is much less stressful, much more tolerable, and that actually works, that people actually have results in their family building journey. So look me up. I'm also on all the socials, Love and Science Fertility on Facebook, Instagram. I'm also on LinkedIn as well. So would love to have a conversation if that would serve you.
Thank you so much. I myself learned so much, and I'm sure that the audience did as well. And thank you so much for also accepting our invitation to come back for
Thank you, Dr.
more
Valerie.
insight on the subject of infertility.
Absolutely.
I do really wanted to tell you that I do really admire your work, and I admire your heart, even for the field and for the people that you serve and the people around you. I got to meet you in person, and you really, truly impacted my life. So thank you so
Oh,
much.
thank you,
I
Dr. Valerie.
wish
It's
you
mutual.
nothing. Absolutely. I wish you
Yeah.
nothing but the best. And if I know somebody that's going through that process, who is in the area where you are or who needs coaching, I'll definitely lead them your way. So
Thank you so
thank you
much.
so much. And my audience, I know, I'm not going to say I hope, I'm going to say I know that you learned a lot from Dr. Erica Bove. And so if you have any question, please don't hesitate to drop them, and she'll be willing to answer any of the questions that you would have. So until we meet next time, you be blessed. Bye bye.